Okay, assalamu alaikum ajma'in. So good morning everyone. So we're going to talk today about two topics or two areas. The first area is part of the imaging of benign gynecological disease, and predominantly I will focus on congenital uterine anomalies. The second part, I will cover malignant imaging of gynae, focusing predominantly on the uterus. And if we have time, I will talk about ovarian malignancies. After that, we will have a little break, and then I will show you a cases covering both topics. And I would like to have some participation from your sides. So starting with imaging of benign gynecological disease, as I always say, it's very important to know and have a very good approach to uterine anomaly. Whenever you look at the pelvis, the first thing I think about is, am I dealing with a gynae disease? And that would include, is it uterine, or is it adnexial, or is it pelvic abnormality related to the So the first part is I will talk about is the approach to uterine anomaly. And to know any uterine anomaly, we have to know the anatomy of the uterus very well. The first question that you would ask yourself whenever you are faced with a gynae cases, ask yourself, are you dealing with a uterine versus extrauterine abnormality? If you get an answer for that, that would be your first step in analyzing any abnormality in the pelvis. Once you identify the abnormality, if it's uterine, your next question would be, am I dealing with congenital abnormality or am I dealing with neoplastic abnormality? And then if it doesn't fit with any of these, then you think about something else. Is it coming from pelvic side wall? Is it coming from somewhere else? So these are the first thing that you always keep in mind whenever you are dealing with a pelvic female cases. So just to cover quickly the uterine anomaly, you always have to think about the ultrasound, CT, and MRI, and you have to know the anatomy very well. Whenever you have a case in the exam or the OSCE or anything, usually we will start with an ultrasound or an X-ray, and then we might move into a cross-sectional imaging. So it is very important that you have to understand and you be very familiar with ultrasound imaging of the pelvis, either trans-abdominal or trans-vaginal ultrasound. So the first thing, when you look here into this ultrasound, you can see clearly that this is the urinary bladder with some fluid, and then you identify the uterus. So the first thing, look at the uterus generally. This is the normal appearance of the uterus that you think. Look at the morphology, the outline of the uterus. Do you have any focal masses? Do you have asymmetric thickening of the uterine wall? If you don't, then you are dealing with a normal uterus. And then you look at the junctional anatomy of the uterus. This is your myometrium, and then this is your endometrium. The myometrium, usually on ultrasound, it's very difficult to differentiate between the junctional zone and the outer myometrium. So generally speaking, I will always look at the myometrium and I compare the anterior wall and the posterior wall. In the endometrium, usually the endometrium, it depends on the cycle of the patient. So if the patient is coming during the secretory phase, you're gonna see that the endometrium is very thickened and it has this appearance with a thin echogenic central line identified. And then you have the outer myometrium. So when the patient come after the cycle immediately, you're gonna see that the myometrium is very compacted, and you're gonna see that there is this thin hypoechoic layer from the subendometrial halo adjacent to a thin echogenic endometrium. So this is once the patient finished her cycle and she's going into the proliferative phase. As we move on into the proliferative phase, you're gonna see this thin echogenic line, and then you're gonna see surrounding hypoechogenicity around the thin echogenic myometrium. As we approach through the proliferative phase, you're going to see your trilaminar sandwich appearance, where you have an echogenic central line with two areas of hypoechoic area around the thin echogenic. So really, once you look at your ultrasound image of the uterus, you should be able to tell, am I dealing with a proliferative phase, secretory phase, or the patient just finished her menstruation? Why would this be very important? Because whenever the patient is coming during premenopausal phase, you have to know which cycle she is in. If she's coming through a proliferative phase and you measure the endometrium measuring 16 millimeter, you don't call it abnormal because this is expected during the secretory phase. However, if you have a postmenopausal woman and she's coming with an endometrium measuring 10 millimeter, you would not ask about the cycle, and you know that this is definitely an abnormal. So moving here into the uterine anomaly, into the uterine anatomy, as we look at the secretory phase again, you can see that now you have a very thickened echogenic endometrium. The measurement is about 17 to 14. So this is a very important measurement that you memorize, because if I have a premenopausal lady coming during the second side of the cycle and she has an endometrium measuring 20 millimeter, this is abnormal. You have to ask for further evaluation and probably biopsy of the endometrium. Corresponding to that, you look moving from here into the uterine anatomy, looking at an MRI. So very similar appearance. However, the MRI is extremely crucial that you understand the junctional anatomy of the uterus. So when I look at mid-sagittal image, and this would be really your image that you want to look at whenever you're evaluating any pelvic abnormality or a female pelvic cases. So the first thing I look at is you have your endometrium. So this is, I know that this is a mid-sagittal image. It's a T2 sequence because you see that the fluid in the urinary bladder is bright. Because the fluid in the urinary bladder is bright, you expect to see that the endometrium is bright. And this is very important to remember. The signal intensity of the endometrium on T2 sequence is very similar to the signal intensity of the urinary bladder. The second part, when moving from the endometrium into the myometrium, you can see zonal differences between the myometrium inner part and the outer part. The inner part, you can clearly identify the junctional zone, which is low signal intensity all around the uterus. The outer myometrium has an intermediate signal intensity. So this is looking at the uterus. If I move lower into the cervix, and this is corresponding, if you look here, so this is the uterus, this is the cervix, you can clearly identify that the endometrium here, the high signal intensity, is continuous with the high signal intensity endocervical gland. So this is another point that you should memorize. Memorize that the signal intensity of the cervical gland is bright as well. And then if you look at the junctional zone of the myometrium, it is continuous with the cervical stroma, low signal intensity. So you can see clearly this is what we call the inner cervical stroma, which is low signal intensity. So these are the important points that you have to memorize. And then you can see sometimes ovaries with follicles in it. If I move into a cross-sectional image of the endometrium, like on axial or short axis, you can see again that the endometrium is high signal intensity, and then you have low signal intensity cervical stroma. So this is at the level of the cervix. You can see the typical ring appearance of the cervix. The cervical gland is high signal intensity. The cervical stroma is a ring of low signal intensity. The outer cervical part is intermediate signal intensity, which is continuous with the outer myometrium. So please memorize this appearance, memorize this image, because this is crucial whenever you are looking at abnormality of the uterus and cervix. And then if you look at the rest of this image here, you have areas of high signal intensity fat around the cervix. This is the area that we call the parametrium. And this is very important because whenever we are doing staging for the cervical cancer, these are the areas that we are looking if there is invasion into the parametrium or not. So just to summarize quickly, your money sequence, the sequence that you would look at is the T2 sequences. It has 3 different zones. It has a high signal intensity endometrium, it has a low signal intensity junctional zone, and then you have an intermediate signal intensity T2 for the outer myometrial layer. The normal thickness of the junctional zone is between 2 to 8 millimeter. If you measure a measurement between 8 and 12, this is what we call an equivocal. However, if the patient is symptomatic, it could be suggestive of adenomyosis. Anything thicker than 12 millimeter, it indicates adenomyosis. Okay, so moving on into congenital uterine anomaly, and this is the first part that I will talk about in this presentation. Congenital uterine anomaly is something that you have to be very familiar about, and you have to have an approach for it. You have to have a step approach. You go through 1, 2, 3, 4 until you reach your final diagnosis for the finding. So the first thing that I always say, your protocoling of the MRI is crucial that it has to be good. There should be minimal artifact. You have always to have what we call a long axis sequence of the uterus. So when we do a sagittal image, on the sagittal image, I will try to ask the technician to take a long sequence along the long axis of the uterus. And hello? So you have the first thing to evaluate the external fundal contour along the long axis. So when we look here, you can see that in the normal uterus, most of the time, you're gonna have a convex outer fundal contour looking like that. So this is your first step in whenever you're evaluating congenital uterine anomaly. Look for a convex uterine outer fundal contour. If the uterine fundal contour is convex to this, similar to what we have here, or it's a little bit flat, you have it like a flat line, then most of the time, either you're dealing with an arcuate uterine or a septated. And this is in cases where you are suspecting congenital, because the normal uterus has a convex outer contour, similar to what we have. So if I'm questioning, for example, this case, am I looking into normal or abnormal uterus? I have a fundal outer convex contour. Okay, so maybe this is a normal uterus. Next step, if it is abnormal, am I dealing with an arcuate or septate? And what is the difference between the two? So the difference is the thickening of the myometrium at the fundus. So if you have a convex outer contour and you have a little dip here, you measure the distance from here to here. If the measurement is less than 1 centimeter, then you are dealing with a normal uterus, probably an arcuate uterus or a normal uterus. If you have slight indentation here and it is measuring that more than 1.5 centimeter, then you are dealing with a septated uterus. So your measurement from the top of the convexity down to the depth of the myometrium will conclude, am I dealing with a normal arcuate uterus or am I dealing with a septated? So the measurement that I usually use is 1.5 centimeters. So if this measurement is 1.5 centimeter or more, then I am dealing with a septated uterus. So this is your first step. The second step is, I'm gonna look at the cleft. What does a cleft mean? It means that if the outer fundal contour is not convex, it is concave, it's going inside the uterus. So the depth of going inside will decide, is it a bicornuate or a didelphys? This is one decision to make. So if I have it going inside, you're gonna measure. I'm gonna show you cases later on. So once you've done your first step, convex, concave, or flat, the next step is you wanna go and evaluate for any renal anomalies. You want to look the number of cervices available, and then you look for the vagina. Do you have a single vagina, two vagina? Do you have a vertical septum or transverse septum within the vagina? These are the points that you always want to check and talk about whenever you have a case of congenital uterine anomaly. So for example, this is the normal uterus that I was talking about. You have, this is the measurement. So if this measurement is 1 centimeter or less, I am dealing with a normal uterus. If this measurement is more than 1 centimeter, then I am dealing with a septated uterus. The second case here that you're looking at, this is the case that I was talking. So you have the outer fundal contour is convex, but you have a little indentation into the endometrium. So now I have to measure from outside down here. What is the total measurement? So the total measurement is about 2.5 centimeter. So this means that I am dealing now with a septated uterus. And in this case, within the septum, you have a well-defined intermediate signal intensity myometrial lesion. So this is something else to evaluate, but you have a differential for that, and most likely are presenting an intramural uterine fibroid within the septum. But our question now, am I dealing with a septated? Yes, I am dealing with a septated. Then your next step, you want to decide, am I dealing with what we call a complete septated uterus or partial septated uterus? What is the difference between the two? The difference between the two, how far the septum is reaching. So if the septum, the muscular or the fibrous septum is reaching into the endocervical os, then I'm dealing with a complete septated uterus. If the septum is reaching into the middle aspect of the uterus or the endometrium, then I am dealing with a partial septated uterus. So if we move to the second case, this is another case. So you look at the case and then you can clearly identify that the uterus has an abnormal configuration. Your first step, as we said before, I looked at the outer fundal contour. So the outer fundal contour, we said it's either convex, flat, or concave. So in this case, you can clearly see that it is concave. So I'm gonna draw a line between the two aspects of the uterine horns that I see, or between the two cornua. And when I'm drawing this, I will go perpendicular from this line into the aspect where I can identify the fundal dip. If the measurements is less than 1 centimeter or 1 centimeter, then I am dealing with a bicornuate uterus. If the measurement is more than that, I am dealing with a didelphys uterus. There is another point that you always have to keep in mind whenever you look at a bicornuate uterus. There is a very important piece of information that has to be present. The piece of information is when you have two separate endometrial horns and two separate endometrial cavities, these endometrial cavities, they have to be continuous, as in this case. So there should be some continuity between the two uterine cavities. If you don't find the continuity between the two uterine cavity, then most likely you are not dealing with a bicornuate uterus. So just to wrap up this case now, we have a concave outer fundal contour. You have a dip measuring about, for example, 1.5 centimeter. And then I have two high signal intensity endometrial cavity. So most likely I am dealing with a bicornuate uterus. Don't forget to look at the cervix, don't forget to look at the vagina. In this case, we have an extra finding. So this case is nice because it have a finding, or it will test your approach about congenital uterine anomaly, and it will test your approach about endometrial abnormality. So if we look at this finding, you can clearly see that I have the left uterine horn is abnormal. It is enlarged if I compare it to the right side. So your next step, I want to decide now, am I dealing with, you remember our first approach, we said, am I dealing with a uterine or extrauterine? So now we know that it is uterine. Your next step, you want to identify what is the origin, what is the epicenter of the abnormality. And when you look here, the epicenter of the abnormality, you have an endometrial-based lesion. You might ask me, why did you say endometrial? And it's an endometrial because the epicenter, it is really coming from the endometrium. I look at the endometrium here, I lose it, and then I find this well-defined, rounded, heterogeneous, predominantly high signal intensity mass within the endometrium. And then when I look, I see that there is a myometrium surrounding this mass all over. So now I decided, and I know that I am dealing with an endometrial-based lesion. So the differential diagnosis for endometrial-based lesion is not much. I always mention it. I used to mention it for you guys when I give you the teaching before, but I always mention that whenever you have an endometrial thickening, regardless, you're seeing it on ultrasound, on MRI, you have about 6 to 7 differential diagnoses. You have to think about endometrial polyps. You have to think about an endometrial malignancy. You have to think about submucosal fibroid. You have to think about gestational trophoblastic disease. You have to think about tamoxifen-induced changes. You have to think about endometrial hyperplasia. So these are the main differential diagnoses that you think about. And there is a way to differentiate between these different differential diagnoses on ultrasound and MRI, and I will show you some cases later. So this case, you have an endometrial-based lesion, heterogeneous signal intensity. The differential diagnosis is the one I just mentioned to you. And then based on the finding on the MR, the signal intensity is slightly heterogeneous. You can see that there are areas of low signal intensity. So I would check the enhancement. If this lesion is strongly enhancing, I would think that I am dealing with an endometrial polyp. However, underlying malignancy cannot be ruled out. And the reason for that, because of presence of these areas of intermediate to low signal intensity within the lesion. So my next step, I would refer the patient for gynecology, for biopsy and correlation with pathology to be sure that there is no underlying malignancy. Okay, so this is something that you have to memorize by heart, guys. These are the different subtypes of congenital uterine anomaly. So if we look here, and I always like to start from down here, this is your normal arcuate version of the uterus. You have the outer fundal contour is convex. You have a little dip. If you measure the distance, it's less than 1.5 centimeters, so it is an arcuate. The counterpart of the arcuate is the septated uterus. And always remember, there are two types of septated uterus. You have the complete septated uterus and you have the partial septated uterus. So if I compare the partial to the arcuate, you can see that the depth of the septum, it is going down. If I measure it, it's going to be more than 1.5 centimeter. To differentiate the partial from the complete septated uterus, I want to see how far this septum is going. If it goes all the way down to the cervical os, I am dealing with a complete septated uterus. If it does not go all the way down, then I am dealing with a partial septated uterus. Once we're done with this, your second step, if you have a fundal dip. So once I have a fundal dip, am I dealing with a bicornuate or am I dealing with a didelphous uterus? So I know that there is a dip. So this dip has to be more than 1 centimeter. This is your first step because sometimes septated can have a little dip, but the dip is not 1 centimeter. So this dip should be more than 1 centimeter. If it's more than 1 centimeter, then I am dealing with one of these. Your next step, I have 2 separate endometrial cavity. So how can I differentiate? The only way to differentiate, as I told you before, presence of communication between the 2 endometrial cavity. So if I have the communication between the 2 endometrial cavity, I am dealing with a bicornuate uterus. If I have completely 2 separate horns with 2 separate endometrial cavities and they are both opening into a single cervix or 2 cervices, then I am dealing with a didelphys uterus. We finish this one and then we're gonna move to this one. This category, guys, is very important. And the reason for that is because it's commonly missed. Commonly missed because the uterus is a slightly smaller in size. However, when you look at the MR image, it's very difficult to identify that it is a small abnormal uterus. So always remember what we say about a unicornuate uterus. Unicornuate uterus is almost looking normal, however, it's a little bit small. So how can I reach to diagnosis? The way to reach to the diagnosis is when you see a single horn deviated to one side, which means that when you look at the endometrial cavity, you will see that it is deviated only to one side, and you're gonna see mainly that there is one adnexial area. You will see the other ovary maybe, but you will see that the endometrial cavity is deviated to one side toward the right fallopian tube. Once I decided that this is a banana-shaped uterus, suggestive of unicornuate uterus, you have very important point to look at. Your important points is, do I have endometrium or I don't? Why? Because sometimes unicornuate uterus, they don't have really endometrium. They just have myometrium with no functional endometrium. So if you have a functional endometrium, your next step, is it communicating with the rudimentary horn? And what's a rudimentary horn? Rudimentary horn is, you know that during the development of the uterus, you have 2 horns that usually they unite together to give you the final appearance of the uterus. So if there is an arrest during the development, you're gonna have the other horn is present, however, it is underdeveloped. So I wanna see if the rudimentary horn or the small size horn is having endometrial lining, which means does it have high signal intensity on T2? This is your number 1 step. Your second step, is it communicating with the normal endometrial cavity in the unicornuate uterus? Based on that, your conclusion gonna be, I am dealing with a unicornuate uterus with or without rudimentary horn, and with or without functional endometrial cavity within the rudimentary horn, and with communication or with no communication with the rudimentary horn. So these are important information whenever you're dealing with unicornuate uterus. The last version of congenital uterine anomaly is when you have hypoplasia or agenesis. So whenever you're looking at the cases, these cases are easily missed. And the reason to miss it, because if you don't have your checklist looking at a female pelvic MRI, you will miss it. So whenever I look, you have to look for the uterus, you have to look for the cervix, you have to look for the vagina, you have to look for the ovaries, you have to look for the rectum, you have to look for the urinary bladder, you have to look for the urethra, you have to look for the pelvic side wall, you have to look at the bones. So you have to have your checklist to go over it and look at it. And once you see it, you have to identify, is each organ available or not? So we covered all of these, guys. The last one that you will not see, I have a single case, and it is because of the DES exposure. That was a long time ago, where you have a hypoplastic uterus with what looks like a T-shaped endometrial cavity that is small and hypoplastic. So sometimes you are faced with hysterosalpingogram image. So this is a case of a hysterosalpingogram. So this might be the first image that they will show you in the exam. So you can see clearly that there is two separate endometrial cavity. However, they are communicating at some point, and you have a cleft identified here. So looking at it, your differential diagnosis based on this image, it is either you are dealing with a septated uterus or a bicornuate uterus. How can I decide? Based on this image, I cannot decide. And the reason for that is because hysterosalpingogram images, you are unable to identify into the outer fundal contour. I have to be looking at the outer fundal contour. How do I do that? Is by looking at the MRI. So this is the same case. You have two separate endometrial cavity. They are probably communicating, and then you have your outer fundal contour is concave. You can see the concavity. However, you remember we said we draw a line here. If the line from between the two horns and reaching to the dip is less than 1 centimeter, then you are dealing with a septated uterus. If the line is going down, then you are dealing with a bicornuate versus didelphys. So here you can see that the line is very small. So I am dealing with a septated, although the outer fundal contour is slightly concave. And then I will measure the depth of the septum. I will see how far it goes. The septum is about 1.5 centimeter or more. And then you can see that there is communication. So I am dealing with a partial septated uterus. What is your next step? Your next step, I would like to look for the cervix. How many cervix do I have? I would look to check the vagina to be sure if there is a transverse or vertical vaginal septum. And I would do a single shot fast pen echo image of the upper abdomen to be sure that there is no congenital uterine anomaly associated. And in this case, you can see that there is an absent left kidney in association with the congenital uterine anomaly we had. So this is just another case. So if we go through the same approach, the outer fundal contour, as you can identify, it has a dip. So I will draw my line between the two horns and I will measure the distance between this. So if the distance is more than centimeter, then I am dealing with a bicornuate uterus. If the distance is less than 1 centimeter, I could be dealing with a septated uterus. So in this case, the distance is about 2 centimeters. So my differential diagnosis is bicornuate versus didelphys. Your next step, you want to check the communication between the two endometrial cavity. So as you can see here, there is communication between the two endometrial cavities. So I am dealing with a bicornuate uterus. What's your next step? Check the cervix, check the vagina, check the upper abdomen for associated congenital kidney abnormalities. Moving on, this is just another case. So you see that there are two separate uterine horns. You can clearly identify that there is a huge dip going down. So here, your differential diagnosis is bicornuate versus didelphys uterus. How can I differentiate? I check if there is a communication between the two uterine horns. When you look at the sagittal image, you see that the endometrial area, the high signal intensity here, the high signal intensity here, it is surrounded by the junctional zone, and the junctional zone is going down into a separate cervix. The junctional zone is going into a separate cervix. You have two separate cervices in this case. You don't have any communication between the junctionals, between the endometrial cavity. So I am dealing with a didelphys uterus with two cervices. Next step, check the vagina, check the ovaries, and check the upper abdomen to be sure about the kidneys. So this is another case. So if you look at this, if you don't pay attention in this case, you can see that there is a uterus. However, this uterus is not the normal uterus that you usually see. You can see that the uterus is deviated to one side. You see, instead of having two cornua going into two fallopian tube, you see that it is pointed upward. And if you are careful, you can see that it looks like a banana shape. So this looks like a banana shape. So here, my conclusion that is I'm dealing with a relatively small size uterine cavity, and it is deviated to one side with banana shape. So I am dealing with a unicorn with uterus. What are the questions that you should ask yourself about? You should ask about, do I see the rudimentary horn? Does the rudimentary horn has an endometrial cavity? If the rudimentary horn has an endometrial cavity, is the endometrial cavity communicates with the endometrial cavity of the other side. So in this case, there is no rudimentary horn can be visualized. There is no functional endometrium, so there is no rudimentary horn. Usually, cases of unicorn with uterus, if you have a rudimentary horn with a functional endometrial cavity, there are few complications that the patient could have. The possible complications are endometriosis, especially if the endometrial cavity is non-communicating because of the retrograde menstruation from the other side, or possibility of ectopic pregnancy that could happen into the rudimentary horn. So I have few cases with these complications. Okay, so we're done with this case. This is just another case. So I'll give you just a few minutes to look at it. So if you don't pay attention, we are looking at pelvis of a female patient because I can see that there is an ovary. So there is something missing here. Usually you have your urinary bladder, you have your rectum, and then you should be able to sew the uterus. So there is no uterus here. And then if I go lower down at the level of the urethra and anus, in this area, usually you have three structures that you should be able to identify. You have the rectum. In the middle, you should be able to see the vagina. And then anteriorly, you should be able to see the urethra. So here you have absent uterus, absent vagina. So you have agenesis of the uterus and vagina, or MRKH syndrome. Okay. This is just another case, guys. So I'll give you just some time to look at it. So this image and the image after, they are for the same patient. So probably on static images, looking at these images a little bit difficult, but here you have a relatively small size uterus. You can see that it is deviated to one side. So once I say that, you should think about a unicorn with uterus. You have a functional endometrium within it. So your next question, I want to check if there is a rudimentary horn. And when you look in other images, you can identify that there is this appearance. So this image is a T1 image. And on T1 out of phase, you can see that there's something identified with areas of high signal intensity on T1 image, suggestive of blood components. And this looks like really like an endometrial cavity. So I had these comments, guys, to make the images bigger. So I'll try to see what can I do. So I don't know if this would be better for you guys, just to keep it like that. Please let me know and put your comments. Okay. So if you look at these images now, here you can see that you have an area of high signal intensity on T1 sequence. It looks like an endometrial cavity, and it is separate from the image that I showed you here. Sorry, guys, because this is, let me move this a little. So if you look here, this is the unicorn with uterus. And what you look here, you can see that on a separate image, you have this area. This is the rudimentary horn with definitely functional endometrial cavity because it has a blood within it. So there is no definite communication between this endometrial cavity and between this. So you're dealing with unicorn with uterus with rudimentary horn with functional endometrium. However, it is non-communicating. So this would be your conclusion. This is just another case. So if you look at the uterus, and don't look at this image now, just look at this one. So this is your normal uterus. You have an endometrial cavity. You have this patient presented with acute abdominal pain. You have this mass-like lesion identified in the region of the left adnexia, intermediate signal intensity image. When you look here on post-gadolinium injection sequences, this part of the uterus is enhancing. This part was peripherally enhancing with areas of high signal intensity central. Just to keep in mind, guys, this patient came with pain and she had a positive beta HCG. So looking at this, this was representing a unicorn with uterus, and you have a rudimentary horn with an ectopic pregnancy within the rudimentary horn. We followed this patient. She received the treatment for ectopic pregnancy, methotrexate. She came up with drop beta HCG and completely resolved, and the patient went home. So by now, guys, I finished the part of congenital uterine anomaly. I'll give you 5-10 minutes. So now it is 10:20. We'll be back 10:30, and I will give you the imaging of malignant gynecological disease.